So the first thing to remember and recognize is that iron deficiency and anemia can be present independently to each other in heart failure. They are both independently associated with worse clinical status and outcomes. We'll look at those numbers a little later, how they can impact with or without each other's presence in terms of outcomes and impact on heart failure, quality of life, and other measures. But the most important thing to, again, hone in is that they do not necessarily need to be present at the same time. And this is reflected in that iron deficiency is poorly linked to red cell indices, especially in heart failure. And this is be seen as independent of erythropoietic status, again, reflecting the same point. Now, when we talk about how prevalent this is, as Dr. Pina mentioned, is very prevalent as a nutritional deficiency around the world, but it also, within the heart failure population, it's quite common. When you look at non-anemic patients with ambulatory heart failure, the prevalence can be close to 60% based on estimates. When you talk about acute heart failure, the prevalence is even probably higher based on estimates. I mean, among women, it can be around 79% and 57% in men. So important to recognize that it's very high and it needs to be recognized and screened and diagnosed. Now, moving on to how does iron deficiency really have impact on heart failure? And this is a commonly seen slide, which is also reflected in the recent Heart Failure Society of America document on iron deficiency. It can impact the erythropoietic status by decreasing hemoglobin content, as well as then having an impact on oxygen delivery. But it also has major extra erythropoietic effects, which are important. It reduces some of the key oxidative enzymes, impacting cardiac energetics, and thus reducing oxygen utilization, but also has direct impact on mitochondrial as well as sarcomeric function, causing reduced output. So again, different ways, and it has impact on overall exercise tolerance in these patients. This all leads to impaired exercise capacity, impaired cognitive function and performance, and also has impact on increased morbidity and mortality, as we will see further down. Looking at what impact it has on prognosis, these are some slides from studies a few years back now. When we look at both anemics and non-anemics, and this is prevalence of iron deficiency, it's quite high. Patients who are non-anemic, and they still have a 43% chance of having iron deficiency, and compared to 61% among anemics. But when you look at what impact they have on outcomes, non-iron deficiency versus iron deficiency, those who were iron deficient had a much lower survival and a higher risk of hospitalization in this particular report. And similar findings have been reported in multiple studies over the years now. It also has a major impact on quality of life. As you can see on this slide, both iron deficiency and anemia both have impact on quality of life. Iron deficiency definitely has a significant independent effect. Moving on to what forms of iron deficiency may be present, there are two distinct forms. There's absolute iron deficiency, which is what is seen in the population with or without heart failure. But what is unique within heart failure population is there's a functional iron deficiency, and we'll delve into those two forms in a second. In terms of absolute iron deficiency, that really reflects to depletion of stores. This could be because of pure nutrition. It could be changes in the gut because of reduced blood flow. These are physiological and functional changes and also impact iron uptake from the gut. But they also may be iron loss due to polypharmacy. There may be patients who are anticoagulation on antiplatelet drugs. There's gastritis, proteinuria from chronic renal disease resulting binding proteins or loss of binding proteins. So all of these factors will actually result in depletion of stores. And then there is functional iron deficiency. Functional iron deficiency is related to a chronic heart failure inflammatory state. And we'll talk about that in the next slide. But this is very different from absolute iron deficiency. And this is where it's important to kind of differentiate between two. Because the absolute iron deficiency is an absolute reduction in iron stores and is diagnosed by a low serum ferritin level less than 30 micrograms per liter. However, functional iron deficiency is there may be an elevated serum ferritin and thus may miss the diagnosis of absolute iron deficiency because of this chronic inflammatory milieu within heart failure. And here the definitions, which are listed in blue on the lower part of the slide, and I'll go through that again as we go through diagnostic algorithms, is even in slightly higher levels of serum ferritin, then there is a focus on transferrin saturation of less than 20%, reflecting that functional iron deficiency in heart failure. And it kind of reflects mostly about this impaired iron metabolism and sequestration of iron. This is a busy slide, and I'll walk you through it. In functional iron deficiency, there's reduced availability of iron because of a generalized inflammatory state, which results in elevations in cytokines, inflammatory markers, and this all results in increased production release of hepcidin, which is the key molecule in this particular condition. It's an acute phase reactant, which is produced in the liver. And what hepcidin does is regulates the release of stored iron from both enterocytes and hepatocytes, so all the iron stores. It also causes degradation of the iron transporter protein, the ferroportin, in the gut. And all this results in trapping of iron in storage and reduced availability. So it's an availability question rather than a total depletion of store question. So this is important to distinguish between two different forms of iron deficiency.